Hello.
Hello. Hi, Ashley.
Hi, Nita. How are you?
Good. How are you?
Doing well.
Thanks so much for doing this. Super excited to hear your talk.
Oh, yes, no problem. I just wanted to make sure you were seeing the right screen. Can you just let me just share and
Okay. Yeah. Right now I see it's not in slideshow mode. I can see
oh, okay,
like
okay.
the stack of slides on the left.
Okay. And what do you see now?
Now it's the presenter mode, the slideshow mode. So it should be good to go in that regard. Yeah.
Okay, awesome.
So, okay, wonderful. Well, we still have a few minutes before the start of the hour, so maybe and then people usually join within a couple minutes after that. So we'll get
Okay.
started like 102, 103, if that works for you.
Yeah, that sounds fine. Yeah.
Okay, great. So just in case you need to grab water or do anything else, there's a few more minutes.
Okay.
Yeah, it looks like you have a pointer. Okay, yeah. Yeah, I can see the pointer too, that you were trying to use that.
Yes. Um, I've been using Teams a lot with some of these
Okay.
meetings. It's very different in Teams, so
It
I
is
always have
very
to,
different.
yeah.
Yes. I I have an easier handle on Zoom than Teams. I'm always struggling with Teams. So, but yeah, this is perfect.
Do I show up in the video too?
Yes, you do.
Yeah, okay. All right.
Yeah.
Great.
How's your academic year going so far? Off to a
You
good
know,
start?
it's a little crazy,
Yes.
beginning of the semester, but
Yes.
I'm down in Florida, so we haven't, knock on wood, the weather's been okay, so I'm
Oh,
feeling
good.
cautiously optimistic.
Okay. Well, that's good.
Yeah. How is it up there?
It's actually been a very lovely fall. So nice and
Oh,
warm and sunny. The leaves are just
mhm.
starting to turn color. So this is one of
Ugh,
my favorite times of year up here.
I miss the foliage. I'm from Toronto. I'm
Oh,
Canadian,
yes.
so that was like the best part was that fall was literally like 3 weeks in Toronto, to be honest. But that foliage was just beautiful. So
Yes. Yes. Hence York University.
yes, yes, York University.
Exactly. Yeah, with climate change, fall lasts a little bit longer now.
Yes.
So it is nice because it used to be that way too here. But yeah,
Yeah.
it is nice.
Well, you all have all the nice lakes, so.
Yes, indeed. Hey, Abby.
Hi, good afternoon.
Huh?
So
Be
actually our
here
fellows.
very shortly.
Okay, sounds good. Yeah, our fellows will be joining from a conference room there.
Cool.
Hence the glow blue. And our audience for our grand rounds is our fellows, our sleep medicine fellows, faculty, APPs, and then if we have any rotating trainees as well. So be a good
Excellent.
mix. Yeah. Just give it another minute or so, and then we'll go ahead and get started. Well, in the interest of time, we will go ahead and start. Hi, everybody. Welcome to today's Grand Rounds. I'm honored to introduce Dr. Ashley Curtis joining us this afternoon. Dr. Curtis obtained her bachelor's, master's, and PhD in psychology from York University. She's currently an assistant professor and the director of the Cognitive Aging, Sleep, and Health, or CASH lab in the College of Nursing at the University of South Florida. Her research focuses on bidirectional associations between sleep and cognition in healthy and pathological aging populations. Her current research investigates how cognitive training impacts sleep, cognition, and associated functions. She also examines sex differences and other risk factors such as pain and medication that alter sleep and cognitive profiles across the lifespan. So excited to learn from you today, Dr. Curtis, and I'll turn it over to you.
Thank you so much. Thank you so much for having me. I'm really pleased to be here. And I just wanted to plug one of our new center at the College of Nursing, the SHINE Science Center, Sleep and Health Innovations and Neurobehavioral Science Center, and I'm the assistant director there. Okay. Okay, so just to give you a bit of an outline, most of my work focuses on modifiable risk factors of Alzheimer's disease. So I'm a cognitive aging researcher, so I not only look at individuals with cognitive impairment, but also healthy cognitive aging. Because the idea really is that we want to potentially mitigate any further risk by targeting these factors before the onset of cognitive impairment. So I'll be sharing some of my work today. I'm going to be talking about 3 studies. So hopefully we'll have lots of time for discussion at the end and can elaborate on anything, and perhaps you all have some amazing insights to share as well. But the first we'll look at sex differences in sleep and cognition. The second study, sex differences in sleep, pain, and cognition. And then the third study is some recently finished work where I'm looking at sex differences in a cognitive bias, a sleep-related attentional bias. We have some interesting results there. And then I'll give you a little bit of info on kind of where I'm headed next. Okay, so everybody in this room, sleep researcher, sleep clinician, right? So we're all very interested and passionate about sleep health. And sleep is one of the modifiable risk factors of Alzheimer's disease. There's been a lot of work done in this area showing that sleep health is very important for our cognitive trajectories, especially as we get kind of in mid to late life. But there's other modifiable risk factors as well. And these kind of encompass a very comprehensive facet of daily life, right? Sleep, pain, anxiety, hypertension, substance use. So all of these, there's a whole wealth of literature out there looking at how deviations or dysfunctions across some of these areas actually increase your risk for Alzheimer's disease and other related dementias. So what I'll be focusing on today, I have looked at some of these other areas in some of my other work, but today I'll be focusing on 2, sleep and pain. And I'll first talk about sleep. And there's actually, although we know that sleep is one of these modifiable risk factors, and like I said, it's a burgeoning area, it's an emerging area. There's lots of funding opportunities in this area. There really is a lack of studies looking at sex differences in not just sleep, but all of the other associated risk factors for Alzheimer's disease that I mentioned as well. So that's kind of where the bulk of my work lies. So why do we want to study sleep and cognition and aging? So I'm going to just present some statistics that I find very alarming, but definitely kind of underlie why I'm really interested in this work. Up to 50% of older adults experience insomnia complaints. So these are the complaints, right? The actual symptoms, trouble falling asleep, trouble staying asleep. And then of those, 12 to 20% of older adults meet the criteria for clinical insomnia disorder. I don't think I need to define that for anyone in this room, but this is chronic insomnia disorder, 3 months or greater, coupled with the daytime dysfunction. And insomnia itself, having the disorder, it actually confers, this is pretty alarming, a 1.5 times greater risk of eventually experiencing Alzheimer's disease, being diagnosed with the disorder. In terms of mild cognitive impairment, so that's that prodromal phase of Alzheimer's disease, where a lot of people that end up with mild cognitive impairment go on to get Alzheimer's disease as well, or transition to Alzheimer's disease. This actually affects 16% of older adults in the US. So again, another statistic that should be ringing some alarm bells. And 45% of MCI patients experience comorbid insomnia. So it is extremely comorbid with MCI. And of course, when you experience this comorbid insomnia, that's only going to make everything worse, right? It's going to exacerbate your cognitive and mood symptoms and just overall kind of more, it's going to impair your daily functioning to a greater extent as well. And MCI and insomnia increase your risk of Alzheimer's disease as well. 10 to 15% of those with MCI develop Alzheimer's disease each year. So that's the incidence rate there. So really, it's imperative. I got at this at the beginning, but it's imperative to kind of look at cognition and treat cognition and associated disruptions like sleep during these windows of opportunity, right? These critical windows before we progress to disorders that you really can't go back from. So before the progression to Alzheimer's disease. So now sex differences, this is the other kind of big part of the talk and a big part of my work as well. Why do we want to look at sex differences? So differences between men and women in sleep and cognition. There are sex differences in the prevalence of sleep disorders and symptoms, and I'll go over a few. So insomnia disorder is more prevalent. It's 2 times more prevalent in women. This is pretty consistent across the lifespan, but as women get older and they experience those hormonal changes that happen in midlife and beyond, this even becomes more problematic. So the statistic is even higher in mid to late life. Women are also more likely than men to report multiple sleep symptoms. So whereas a man might just report one sleep symptom, women are more likely to report an array. So poor sleep quality, difficult initiating and maintaining sleep, sleep arousals, and early morning awakenings. Men, on the other hand, are 3 times more likely to report snoring and sleep disorder breathing. So in men, we look at the literature on OSA, so obstructive sleep apnea. What we find is that in men, OSA is associated with a 2.5 greater risk than women in developing Alzheimer's disease. So again, that's some of the literature that has been published to date. And again, that's pretty alarming, potentially suggesting these sex-specific risks that might be happening here in terms of how sleep health might confer, dysfunctions of sleep health might confer greater risk depending on your sex. In terms of our CPAP evidence, there's mixed evidence regarding whether men are less likely to adhere to CPAP. And OSA, as we all know, is extremely underdiagnosed in women. So again, just kind of looking at this, there are these obvious sex and gender differences, and they're just kind of being not necessarily ignored in the literature, but they aren't really doing these sex balance studies to potentially uncover some of the mechanisms that might be driving these. Okay, so why do we want to study sex differences in the relationship, the sleep and cognition? In terms of my background is actually cognitive psychology, so I studied a lot of this kind of coming up in my training, but there are known sex differences in cognitive function. These are very well known. In women, verbal learning and memory and psychomotor speed are better in older women versus men. And then visual spatial ability is better in men, as much as we don't want to admit it. Visual spatial directional ability is just better in men. That's one thing that has been proven, I will say, in the literature, supported by findings in the literature. Women also have a higher prevalence of non-amnestic MCI. So I mentioned the prodromal phase of Alzheimer's disease. This typically is amnestic MCI, although now the criteria is kind of changing. There's been some newer criteria coming out that's kind of different from our traditional Mayo Clinic criteria. But women do have this higher prevalence of the non-amnestic kind. And usually the non-amnestic kind can involve it's not primarily a memory issue, but many areas of cognitive functioning that are disrupted. In non-dementia older adults as well, women show faster decline in global cognition and executive function. So that right there is important, because that suggests, again, that critical window of opportunity. If women are declining faster than men in some of these areas of functioning, we need to get to them sooner. And then, of course, 2 times more women than men have Alzheimer's disease. This is a statistic that's been repeated over and over again, and it's not just due to the fact that they live longer. It's not just due to the increased longevity. There are other things happening here. So a lot of the work that I do is digging down into that, looking at some of these sex-specific modifiable risk factors, looking at the patterns, saying, okay, what might be more problematic in women versus men, and vice versa, studying sex differences. If we find something for men, that's also really good for understanding and ruling out things that might not be as much of a problem for women. So the first study I wanted to talk about was published last year in Behavioral Sleep Medicine. So this was a study looking at sex differences in sleep and cognition. And it was in middle-aged and older adults. They were in the US. This was a study I actually conducted during kind of the height of COVID, actually. It was in July, August 2020. So they were cognitively healthy. We had a really extensive screening process. So they were cognitively healthy, no neurological disorders or dementia, pretty healthy otherwise, no major medical illnesses or psychopathology. And we had them do an online survey and then objective cognitive test assessment. So we had them do the PSCI for sleep. So that's asking about your sleep quality over the last month. And it gives us lots of good information. It gives us different metrics. So your global sleep quality, sure, the overall metric, but it also gives us subjective sleep quality ratings. It gives us sleep duration and it gives us sleep efficiency. And for our cognitive assessments, we did this was during COVID, so we did something, Inquisit Web is what we used, and this was online. And we administered 3 different types of tasks. And this was great because they correlate really well with in-person lab tasks. And we administer it at home on someone's computer, and then we get a really good kind of wealth of knowledge in terms of metrics that encompass the full range of cognitive processing. So with the Posner, this is, you're kind of cueing someone left and right, and you're measuring their reaction time and how good they are at detecting a target, but also how good they are at inhibiting a target that is not correct and going back to the other target. So this gives us spatial attention, endogenous orienting. If you're a cognitive person, this just means kind of top down, where you're actually making that conscious decision to move your attention. And we look at reaction time, like I said. We also use the Stroop. This gives us processing speed, attention, and inhibition. This is just where you're responding. You have to ignore the written word and respond to the color. So you're kind of inhibiting that prepotent response. But we get all of these different types of trials. So it gives us really, kind of from bottom up to executive function. It gives us a nice grouping of cognitive function. And then we use the Sternberg task. This is just a working memory task. Okay. So here's our participant characteristics. So it was a smaller sample, but it was sex balanced, 32 men, 31 women. They were a bit on the younger of the older age because they had to be 50 and up. And our sleep variables here, if we look at the PSCI, in terms of the cutoff, this is very typical of older adults, right? So the cutoff is 5 for the PSCI for sleep disturbance, and they were over the cutoff here. Men were slightly worse, but this wasn't a significant difference. And then just in terms of our sleep quality, sleep duration, and sleep efficiency, sleep efficiency, 88, 89, so a little higher, but still, not optimal. And then sleep duration as well, a little lower than what you want for that optimal number of hours slept. For our cognitive tasks, these don't really mean much out of context, but we did have some differences here between men and women. So the Sternberg task and the Stroop interference, women were actually better for the working memory, which is not surprising. That's consistent with the literature. And then for the Stroop interference, women were actually also better. They were better able to inhibit the prepotent response. Okay, so what did we find? We found two really interesting findings that were consistent with each other, just in terms of the sex piece of it. So we found, let me just kind of orient you to this graph. I've made it really easy, where women are pink, red, and the men here are blue. And what we found was that sex interacted with PSCI sleep quality in the association with this attentional orienting. So we found here, you can see looking at the slope, this is just a regression line here with our sleep quality along the x-axis, our attentional orienting along the y. For attentional orienting, if it takes you longer to do the task, that means you're worse at it, right? So you can kind of see here, because it's a positive slope, worse sleep quality here was associated with worse attentional orienting only in women, right? So we did not see this in men. We also found the exact same pattern for another cognitive task. So for the Stroop control trials, which measures processing speed, we found the same thing. So sex interacted with PSCI sleep efficiency in the association with the Stroop control trial performance. And same thing here. So worse sleep efficiency, so as you go down here, is associated with the higher reaction time. So that means worse performance. So worse sleep efficiency was associated with slower processing speed in women, but not men. So this was good just in terms of it being consistent, and was really able to kind of show us these potential really specific sleep and cognitive relationships that might be sex specific. Okay, so you can read, I'm happy to send you the paper as well, if anyone's interested in it, published in BSM, but just in terms of what we talked about in the paper for the discussion and the implications of this, there's a lot. It is cross-sectional, so we're limited there, but having this kind of rich data set, looking at, a sex balance sample, looking at an array of cognitive tasks and really digging into your sleep patterns and looking at those specific metrics, we were able to make some, poignant points in the discussion. So in terms of what this might mean, when we measure cognition, really what we're trying to do is have implications for what might be happening in the brain, right? So there are age and sleep-related neural mechanisms that might be at play here. So because we found these sleep and cognition associations that were sex-specific, we go to the literature. So we know that poor sleep quality is associated with reduced frontoparietal network connectivity. That's something that's been shown in the literature in aging adults. We also know that lower sleep efficiency, this has been associated with a greater white matter hyperintensity burden and neuroimmune response. So again, if we kind of go to that literature, we can start to unpack or point to potential mechanisms that might be at play in driving these results. So they might be interacting, these age and sleep-related neural mechanisms, with sex mechanisms, right? So we know that women, the age, as I showed you, was around kind of early 60s, 62, 63. So most of these women were postmenopausal. And we actually did have that data where we looked at kind of their menopausal staging. And it was a very, very high number that were out of perimenopause and the postmenopause. So we know that they kind of already went through that, menopausal transition. They had that large hormonal drop. So when you get that drop in the circulating progesterone, what happens is in the literature, what it shows is that there's a lot of progesterone receptors in the frontal cortex. And we also know that the frontal cortex is involved in spatial attention. So what might be happening here is you're getting, this interaction between the sex hormone circulating changes, these sleep changes, and that's actually impacting specific areas of the brain, and that's showing up in these cognitive performance metrics. We also know that greater neuroimmune response, this also affects white matter integrity. And we know white matter integrity is associated with how fast you can process information. So you really can kind of point to potential things that might be happening in the brain here. So what's the relevance here? Why do we care? This top-down control of spatial attention, so not something that's reflexive, but actually you having to change your mind and move your attention. This is affected early in MCI and Alzheimer's disease. It's one of the first things that we notice in the clinic when you're giving someone an assessment in these early stages before they're even experiencing the pathology of Alzheimer's disease. So this could, for relevance for cognitive impairment, this could be something we want to look for. And if you are actually experiencing this, you might also want to measure their sleep, because we could be, pointing to potential things we could go in and modify. And we also know that processing speed is associated with our ADLs, our activities of daily living at MCI. So again, if you're seeing some of these cognitive deficits or these dysfunctions, we might want to go in and target sleep. So again, targeting potential specific sleep metrics, so subjective sleep quality and sleep efficiency. These might be targets, not just for intervention, but for monitoring, particularly in women. Okay, so I don't think there's any questions, but I'm happy to take questions, but there's time at the end to also have a discussion. Okay, so the next study is sleep and pain. So surprisingly, in older adults, 50% experience insomnia symptoms. Like I said, 30% experience chronic pain, right? And these are very often comorbid. If you have one, usually you have the other, and this reciprocal relationship, and they exacerbate each other. We know that chronic pain, this is a really well-established finding, is associated with worse cognition, and pretty broad across a range of domains, right? So we're seeing this across a range of cognitive functioning. And then we also know that when we look at where the chronic pain is, there's some interesting findings there. So if you have pain in a single area, this is linked to a 15% greater risk of all-cause dementia. And if you have multi-site, chronic, widespread multi-site pain, this is associated, not surprisingly, with a much greater risk of dementia, 35%, and a 45% greater risk of Alzheimer's dementia. So chronic pain, it can limit what you can do, right? If you're in pain, you're not going to be able to actively participate in some of these health promoting behaviors that can decrease your risk of Alzheimer's disease. And surprisingly, when you go to the literature, there's a lack of studies that looking at how chronic pain might actually impact the sleep and cognition relationship. In my lab and some of my collaborators, we were some of the first to actually look at this. So the few conducted, we've previously found that worse sleep associated with worse cognition in the presence of more pain in these older adults. It was an interactive relationship. So the worse sleep was only associated with worse cognition in that presence of more pain. And there's actually a lack of studies almost completely looking at sex differences in this interactive relationship. So that's where we come in. So that's what this is. This is a study. We're writing it up now. One of my graduate students is writing it up. This was funded by the MU School of Medicine. Okay, so this was a study. This was the same sample that we used before with the COVID study I did in 2020. So it was 275 middle-aged and older adults. We're able to use the whole sample this time, and it had the same inclusion and exclusion criteria as before. So this time we had the PSCI, same thing as before. We also recorded their pain. So did you experience pain, chronic pain in the last 3 months? We do have data on where the pain was that we present in the participant characteristics table, but I won't be presenting that today, but it'll be in the paper when it comes out. And then in cognition, this time we looked at self-reported cognition. So self-reported cognition is a good indicator of not necessarily of their current objective cognition, but it's a good indicator of risk of Alzheimer's disease. So often if you're complaining of these cognitive failures, right, you're having memory issues, you get distracted easily, you have these social and physical blunders, that's a really good indication of the risk you might be at for experiencing not just kind of mild cognitive impairment, but more serious Alzheimer's disease as well. So here is our condensed participant characteristics table. So we had a pretty decent sample in terms of our pain absent and our pain present. So they were pretty, we had more people with pain present, but still a decent sample here. 64 was around the average age. In terms of our PSCI, because this was the larger sample, and not just the ones with the objective cognition, the total scores were a little higher here, but still kind of in that area of meeting the cutoff for the PSCI. And then in terms of our CFQ, if you're familiar with it, it's the Cognitive Failures Questionnaire. The cutoff for kind of self-reported cognitive impairment is around 32. So that was around the average here. So these were older adults that, were experiencing, some of these areas of concern that might lead to, greater risk of experiencing dementia down the line. Okay, so here this time, I don't have the pretty color coding for men and women, but what I did this time was color coded by pain absent and pain present. So pain present is the bad one, red, and then pain absent is blue. And we have here for the CFQ total, so just like an overall index of how many cognitive complaints you're experiencing. Then we have memory here in the middle, and then we have the blunders. And then the men are on the left and the women are on the right. We did subjective sleep quality. That's what we found. A lot of our findings, the other findings were null, but we had significant findings for subjective sleep quality on the PSCI. So what did we find? So in men with pain absent, worse subjective sleep quality was associated with two things: worse subjective global cognition and blunders. So that's this positive slope line here, right? So as their subjective sleep quality gets worse, they're reporting more cognitive complaints. And that was a consistent finding. For women, on the other hand, we only found this for pain present. So for women with pain present, worse subjective sleep quality was associated with worse subjective memory. Okay, so again, very kind of specific, consistent, but specific, sex-specific relationships happening here. So what does this mean? What it might mean is that there's this, unique, dynamic, sex-specific relationship between pain, sleep, and cognition. So it might be important to monitor pain when we're looking at sleep quality in aging women. And this, because we found that in men, we only found the association with pain absent, but in women, we found that, more disastrous, association between the sleep and cognition. And we only found it for subjective memory complaints. And this is key because subjective memory complaints are the ones that are most likely linked to your increased risk of experiencing more severe cognitive decline, which is not surprising because Alzheimer's is, primarily when you think of it as a memory disease. For men, even those who did not report pain, they might be just generally at risk of future cognitive decline. And again, this is to be taken with a grain of salt. This is, the caveat here is that it's cross-sectional. So we're doing some longitudinal work now to hopefully try to extend some of these findings. So we really need to look at prospective studies. So what might be happening? Sex might be modulating the pain pathway in the brain and exacerbating the impact of poor sleep health on cognition. And this is, I mean, there's lots of studies. They do a lot of work at the University of Florida and also some work in Michigan as well, looking at kind of the sex modulation of the central pain pathway. And this is something I think we need to look more into because, again, going back to the female sex-specific hormones, they might play an important role in the downstream pain signaling, looking at where the progesterone and estrogen receptors are in the brain, and looking at, when you get those cyclic changes that are happening during menopause and beyond, there might be something happening here that's causing, when you get one or more interactive factors, you're getting a more disastrous effect on cognitive functioning in the brain. Another piece here, just to kind of think about, I talk about sex a lot, sex differences, but these gender specific factors might be playing a role too, because we're asking people to evaluate their pain, right? We're not going in, there really isn't a way to objectively measure pain, right? Unless you look at the neural response in the brain. You're asking people to rate their pain, and people have different thresholds here. So there is some work looking at kind of, if you give someone information about the pain they might be experiencing, that can change their pain ratings, so their effective evaluations, and then also change their objective pain thresholds. Right, so even though you're asking someone to rate their pain, you could give them a painful stimulus and measure things on the face or indicators of a pain response. So that's some things that we can continue to look at, I think, that are important. And there is some work suggesting that there might be some gender differences there. Okay, so the final study I just wanted to touch on is one that I recently finished writing this one up as well, funded by the ASM Foundation. So this was a study called Cues. We were looking at sleep-related attentional bias and looking at sex differences there. And I'll go through what all that means. So sleep-related attentional bias. I already went over about, the stark statistic about older adults having insomnia, 50% of them. In terms of what sleep-related attentional bias is, it comes from the cognitive model for insomnia, so the attention, intention, effort, AIE pathway. So what this means is you have this excessive preoccupation with sleep, and it biases your attention towards sleep-related stimuli. And that's what it's called, the sleep-related attentional bias. And what this does is it contributes to the persistence of your insomnia symptoms. So I have a little schematic here just to kind of illustrate what that might look like. So you have this gentleman here lying in bed, ruminating. He's having trouble falling or staying asleep. And what he's doing is he's paying attention to these sleep-related cues, right? So he's looking at the wall. It's 3 a.m. He hasn't slept yet. He's looking at his partner on the other side. She's sleeping peacefully. Why can't I? Right. So you're really kind of paying attention to these sleep-related cues. He's listening to the ticking of the clock on the wall, right? All these things are capturing his attention. So this can lead to sleep-related cognitive effects, right? So these negative thoughts, I'm never going to sleep again. Also, like the emotional effect, the negative valence, you feel terrible about it. So this can combine with that capture can lead to hyperarousal and distress. And we all know that that will only, allow cause the insomnia symptoms to persist. So it's kind of a double-edged sword, but reciprocal. And it's this cycle that kind of never ends. So the idea for this is, okay, let's go in here and figure out what might be actually driving these sleep-related attentional biases, and are there sex differences here? So when I went to the literature, when I was, first writing up this grant, again, I always go to literature and kind of see who's looking at this. Despite the high prevalence of insomnia in older adults, there really is a lack of studies looking at sleep-related attention bias in this population. And it's really unclear, I was giving you examples, looking at the clock, looking at the wife sleeping, looking at the window, seeing the moon, hearing the ticking of the clock. We don't really know if it's just visual stimuli that might be driving this attentional bias, or if it might occur for other sensory modalities like auditory. And that's important for treatment. There are ways that we can fix your attention, right? We can train you to reorient your attention and not pay attention to things that are causing you distress. So if we can go in and figure out what might be driving this definitely has implications for treatment. So that's what we wanted to do. We wanted to compare visual and auditory stimuli for those with insomnia versus those without. And then we also want to look at these sex differences. And the hypothesis was this, and I'm saying the hypothesis because the results, spoiler alert, were inconsistent with the hypothesis. we actually expected, because women are more likely to have insomnia, originally I thought that it might be due to this cognitive bias, right? This attentional cognitive bias that they're experiencing. And I thought we'd see it'd be more prominent in women than men, especially if they had insomnia. Okay, so we had 81 older adults, 60 and up, cognitively healthy, stabilized on sleep medications if they were on them. So they had to at least be on them for 6 weeks. And they still had the insomnia status. So we had people with insomnia and people without. For insomnia, we used the definition I said earlier for the DSM-5 criteria. And then we had them do these cueing paradigms. So Posner cueing and dot probe, I'll show you a schematic in just a moment. Not really important, but what's important is that we were looking at visual and auditory stimuli here, like I said. So this was a challenge. Being a cognitive psychologist, a lot of the early work that I did was programming these cognitive paradigms on a computer, right? So we can use these really well-established cognitive paradigms, but when you have to create new stimuli, that definitely can be a challenge because you have to validate it. So what we did was we had our visual stimuli came from the International Affective Picture System. They were gracious enough to provide us with a permission to use their stimuli, and they have some great visual stimuli. So these are related to insomnia or neutral, but these ones obviously are related to insomnia. You can tell down here, but we had to validate it in middle-aged and older adults because there isn't really a lot of work done in this area in that population. So we validated it in a sample that we had, and we had them rate these pictures. How much is this related to trouble falling in or staying asleep? And they rated it for us. For the auditory, there was nothing really we could use out there that was already programmed. So we did our own. We created our own sounds, and we did the same thing. We created all these sounds kind of based on the literature and what we knew might be impacting people's sleep. And then we had them rated. Again, how much is this related to trouble falling or staying asleep? So we did our due diligence there. So for our visual stimuli, the highest ratings were like 4.5 out of 7. And now the neutral non-sleep related stimuli just came from the already validated ones from the IAPS study. And then for the auditory, this is really interesting. These were the ones that were most highly rated. So snoring, heavy breathing, an alarm, not surprisingly, baby crying, and dog barking. So there were other ones as well, but these were the ones that were rated the highest, most likely to interfere with sleep. For the neutral tones here, the neutral auditory tones, when you think of non-sleep related ones, we just used a pure tone and we varied the frequency so that you wouldn't habituate to it. Okay, so this was the task here, the Posner task. Basically what it looks like, we're just cueing them left or right, and then they're responding to the target. So our outcomes of interest here are cueing effects. So you're just looking at that reaction time difference between the non-cued reaction time and then the mean validly cued reaction time. So you're cueing them either left or right to this sleep target or this non-cued target. And same thing with the auditory. I'm not going to go through kind of the details here, but you're really just looking for that difference in the reaction times here. Dot probe, it's pretty much the same thing. We just don't have the kind of interval, the same interval between the cue and the target, but we're basically doing the same thing. We're presenting both of the targets at the same time, both of the cues at the same time to the top and the bottom. And the idea is that if you have insomnia, you're going to pay more attention to the sleep-related cue, and you're going to respond more quickly to that area. So again, you look at that difference in the reaction times to get your outcome. Okay, so here are participant characteristics. We had more people without insomnia than with insomnia. I will say it was a pretty strict criteria, so that kind of makes sense. We also had more women than men with insomnia and a more equal split in the non-insomnia. For our ISI, there was actually a sex difference here, and this will become important in a minute when I show you the results. For the women with insomnia, they had actually lower ISI than the men, and that was a significant difference. So the men were reporting worse insomnia symptoms than women. No difference in the non-insomnia. Okay, so what did we find? So we found some interesting results here. Our men are on the left, our women are on the right. Insomnia is in blue, non-insomnia is in gray, and then our cueing effect is here on the y-axis. So a greater cueing effect in this case, same thing as before, it's worse performance. It means you're paying more attention to the sleep-related cue, and it's really hard for you to reorient your attention away from that cue. So higher here, worse attentional bias. So we found a significant interaction between insomnia status and sex for the visual sleep-related cueing, the valid sleep-related cueing. So in men, on the left side here, there was a larger trending cueing effect for those with insomnia versus those without. We have a few more men to add to the mix here, so I'm hoping that that comes out to significant. For the invalid sleep-related cueing, they're basically two sides of the same coin. One is just the invalid cue, they have to do more work. But in terms of because they have to really reorient their attention, in terms of what the actual outcome means, the qualification is the same. Okay, so in men here, we found a larger cueing effect for those with insomnia versus those without. So you can see this here, very, very striking between the insomnia and non-insomnia. And we also found a larger cueing effect than women with insomnia. So here's where this actually came out. For the invalid cueing effect, where it's harder, we did find that sex difference here. So they were worse than women with insomnia. Okay, so kind of for the auditory cues, we didn't find any sex differences here. We actually found a consistent pattern of results. So I'm just going to put them all up here. If you can look at what these graphs look like, they look very similar. So we have our auditory valid sleep-related cueing effect here and our auditory valid non-sleep-related cueing effect. So not only did we not have any sex differences here, with the auditory cues, it didn't matter if it was a sleep-related cue or a non-sleep-related cue. We found the same pattern of results. It only depended on whether or not they had insomnia. So larger valid cueing effects for both sleep and non-sleep related cues for those with insomnia. And you can clearly see that, right? So the blue line, the blue bar here is significantly higher than the gray. Same thing here, same pattern of results. So kind of putting these together, what we found was that contrary to what we thought, men with insomnia experience larger visual sleep-related attentional bias than women with insomnia. And we're going to add some more men into the mix, but just in terms of thinking about what this might mean, if you think, before I was talking about progesterone and estrogen receptors in the brain, when we think about for men, circulating testosterone and spatial attention, right? So there might be something happening here kind of that has some ecological validity in terms of if you think about history. So men might be more likely to pay attention to something that's threatening, right? So that's been shown in the cognitive literature where, men that see something, a picture of violence, they're more likely to respond to it, or something that might need protection. They're more likely to more quickly react to it than women. So we might be seeing the same thing with this insomnia stimuli. So sleep-related stimuli, the threat of it might cause them to react more quickly to it and really pay attention to it more. And it could study as the men did have higher, they reported anyhow with the ISI, more severe insomnia symptoms than the women. So that's a caveat. And then in terms of the women, this is a thought that I had, and there is some evidence of this in the literature as well. What might be happening for women? So these are middle to older. These are actually all older adults. So usually, you see sleep patients, this. When you see older adults with insomnia, typically they've had it for years and years, some of them decades, right? So what might be happening here is that you're getting this habituation of sleep-related stimuli in women, right? So they're habituating over time. You're less likely to see a difference between your sleep-related stimuli and your non-sleep-related stimuli because they're just responding to all stimuli. There's also, if we go to the cognitive psychology literature, women are actually more likely to see stimuli as part of the entire environment rather than a distinct entity. So that could also be at play. They're more likely to pay attention to the whole screen rather than the specific sleep stimuli. And then the other kind of, easiest explanation would just be, well, maybe it's not cognitive sleep-related bias in women. Maybe that's not what's driving their insomnia. It's other things, right? Arousal, pain. We talked about hormone changes, immune status, higher order maladaptive thoughts. Maybe it's not this kind of basic cognitive psychology. It's these other thoughts that are driving kind of these metacognitions that are driving their insomnia. In terms of our auditory attentional bias, this is pretty easy to explain. What we think is the greater general auditory attentional bias in insomnia probably just reflects general auditory cortex hypervigilance. People with insomnia are hyperaroused and they're just going to respond quickly to any stimuli that's grabbing their attention. So what this might mean in terms of clinical implication, aging adults with insomnia, they might benefit from something called stimulus desensitization towards insomnia triggers across sensory modalities. So it doesn't look like, you're really getting, even though we have the insomnia specific issue with the visual stimuli and that sex difference, we're also seeing the insomnia specific pattern for auditory stimuli, but it doesn't matter what the auditory stimuli is. So stimulus desensitization, this is, I guess most notably characterized as exposure therapy, kind of in pop psychology culture, but it's basically conditioning. So you're afraid of rabbits. That's your conditioned stimulus. You like cookies, so you pair the rabbit with the cookies over and over and over again, and then eventually when they present the conditioned stimulus, it becomes conditioned. The rabbit, you're no longer afraid of it, right? So it's a systematic, repeated exposure to stimuli in a non-threatening condition. So it's graded exposure, and eventually you relax. So potential interventions here in terms of cognitive interventions, which is what I do in my lab, potentially exposing this to stimuli, sleep-related stimuli in a cueing paradigm, retraining them to reward faster reaction to non-sleep stimuli. They actually do this in macaques in some preclinical research. So you could pair sleep-related stimuli with emotionally positive stimuli to condition a non-anxious response. So that's kind of where I see the results of this potentially going. Okay, so future directions. So obviously looking into some of those cognitive trainings and these cognitive paradigms, but also doing some longitudinal work. So I'm finishing up a study called MidVista. It was funded by the Women's Health Collaborative Grant, and we have data on women across the menopausal spectrum, and we're looking at longitudinal associations between sleep, pain, and cognition. So I'm really excited to dig into that data this fall and hopefully publish next year and present on it. We also want to look more closely at mechanisms, so the physiological mechanisms and moderators that might be driving some of our results. So inflammation, sex story interactions, also doing some imaging, looking at the brain. Again, cueing paradigms, like I said, doing some neuroimaging. We have some studies, progress looking at that. I put COMISA on here because I've only been talking about insomnia, but COMISA, definitely a hot topic right now, and also kind of looking at that and looking at it in the data as well, because we have AHI data, PSG in our previous study that we can kind of look at here. And behavioral interventions, so not just, kind of cognitive interventions like stimulus desensitization, but also potentially some multimodal interventions. So I developed a cognitive training. It's not sleep-related attentional bias, but it's more kind of traditional cognitive training, but we're pairing it with other behavioral interventions like music listening. And I could envision even looking at it in CBTI as well, or adding some of these cognitive paradigms into CBTI, which is our frontline treatment for insomnia. Okay, so just acknowledging collaborators, students, and funding mechanisms. And I left some time to have a chat. So hopefully we can have a discussion, and happy to take any questions as well.
That was fantastic. Thank you so much. I think Neeraj Kapleesh had a question.
No, it was not typically a question, Ashley. Thank you so much for presenting. I think I was kind of, just from a clinical perspective, when I think women are more descriptive of their dreams, even socially as well. I was wondering whether that has something that you have also been looked into the literature, suggest something, whether the bad dreams or dream recall or mentation is typically gender differences.
I love that. I used to do dream research way back when and kind of pivoted. But I think you're absolutely right. So women, there's some evidence showing that they remember more vivid detail in their dreams, which is to me completely obvious because of the verbal memory. They're able to kind of remember some of the details that are happening. And I mean, not just that, they're more likely to share. I mean, I'm constantly telling people if I have a bad dream and I tell the story, I probably tell it more than once as well, kind of reinforcing that. So I think there might be sex differences and gender roles kind of playing into that. I think that's a really fascinating area though. So would like to think about that some more and come up with some ideas.
I think if you can go to your initial slides, I just wanted to clinically, where you were talking about the PSQI and the sleep efficiency.
Yes.
use certain thresholds to kind of define poor, average. I just was
Mhm.
trying to see clinically, in research world, the definitions may be different.
Yeah.
But what did you define the thresholds for each category? For example, here.
Yeah.
So in the graph, sorry, the next slide, go forward one, yeah. So for example, here, very good, fairly good.
Oh, yeah.
So what
Yeah.
are the thresholds that, how do you define?
Yes, thank you for asking that question. So these are the simple slopes, and what we used was the average would be the average of the sleep efficiency. So I think with us it was 89%. The highest would be one standard deviation above that, and lowest would be one standard deviation below that. That's how we set the simple slopes here. You could do some other simple slope analyses where you looked at more of the extremes of that. So just in terms of if we look at the SD, so 89 with a 13 standard deviation. So these are imputed as well. So sometimes it doesn't necessarily reflect the entire range of the response, but our one standard deviation above, the highest would be like right at 100%. Lower would be 75% for sleep efficiency. Same thing with, sorry, go ahead.
So I'm just trying to make sure I understand it, because it seems to me this whole data kind of is leading what we consider to be a normal sleep efficiency, probably close to 89 to 90% or higher. So this is on average is kind of 90%. So I don't, well, I think you are having a population-based data, so you're likely going to come up with healthy people that you're looking into, or relatively healthy people with. So I just trying to make sure that how do we imply that these are clinically speaking normal sleep efficiencies, I guess.
Yeah. And I think too, like, so this is a regression analysis with simple slopes. So it really is the slope that we're evaluating, right? So it's more, if you think of it, you can set your limits, the pattern's going to be the same, right? So the slope is going to be the same pattern. It's just you can extend it out if you're imputing it on a population health level. But really what we're looking at is the slope. So as your sleep quality gets worse, right, we're seeing this pattern of results. So you could extrapolate that more broadly and say, yes, our people might be at 89%, but because we have that range, where there were some people in the lower range, when we look at the overall pattern of that slope, it's likely to hopefully be something we can consistently replicate in a larger sample. And same thing with the sleep efficiency, it's the slope. So as your sleep efficiency gets lower, we're seeing, so it's right, the consistent slope here, you're getting that worse processing speed.
But I think if I understand that is that if you are having near normal values, then you need to be powered enough to have a larger sample to show a difference. Is that correct assessment?
Yeah, so this we did our power just based on the number of predictors, right? So we controlled for age and education in our insomnia sample. We looked at some other ones too, but we made sure that this one was a sample of 63, right? So we can have six predictors.
Yeah.
Great, thank you. I think there's a question from our fellows.
Yes.
Hi, I have a question. Were the studies, did you control for medications like for pain or insomnia? And then also my question is, it's like not related to these studies, but just like in dementia in general, like I'm under the impression that like less REM sleep is associated with dementia, and so like with like REM suppressant medications, is that a risk for dementia?
Yeah. I'll answer your first question, the medication. So we always look at the medication. We built the sleep medication into our inclusion criteria. So these people coming in are stabilized on it and they still have insomnia, right? In a lot of the trials that we do. But we always look at it. If we can't control for it, we put it directly into the model. But usually we'll do like first order, zero order correlations just to see if it's at all even associated with our outcome. And these samples, no. Our sleep and pain were not, medications were not associated. Not surprising to me, just because of the fact that they were older and a lot of them have been on these for a while, and they're still experiencing the symptoms. When we do, neuroimaging studies and things more acutely, then, we build that into the instructions and we look at it at the daily level. We actually do have some daily data too, some diary data where we have like, did you take a sleep med this day or a pain med this day? We just haven't unpacked that yet, but you're giving me an idea now. I think we maybe want to go look at that as well. Your other question, REM. Oh, I love that question. So Yeah, so traditionally, it was thought that the slow wave sleep was really driving potential dementia risk. And then the last 5 years, a lot of work has come out looking at REM sleep. And not just the amount of REM sleep, but the spectral power in REM sleep. So we have a follow-up study to this one where we're actually like showing that we're getting this kind of spectral power in REM sleep that is associated with cognitive functioning. So I think that's kind of a burgeoning area of research. And then your other question was about REM sleep suppressant. Was that your question about?
Yeah, like SSRIs, are notorious for
Yeah.
inhibiting REM
Yeah.
sleep.
Yeah, I think that I think that's bad. Right. So the idea is that you want to complete the sleep cycle, and really is the slow wave sleep and REM that's probably giving you the most restorative, positive impact on your cognitive functioning. So I think anything that's going to hurt that. So not just SSRIs, alcohol use, right? So we have another paper coming out looking at that, and we have some sex-specific effects as well, where it's really impacting those areas of sleep that you need the most. You need the most consolidated. We don't want them to wake up from it to really get the most benefit from your sleep. So I think all of that is important to measure and consider.
Thank you.
Actually, I have a question. You articulated really well kind of some of the potential differences in intervention based on these sex-specific differences. And I was wondering your thoughts about, do we need to adapt our diagnostic criteria, understanding some of these nuances? Are we missing things, or are we overly lumping when we should be more nuanced?
Yeah, I think the issue, like my opinion, yes, I think so. I don't think we're there yet. So a lot of the work, I presented a bunch of cross-sectional data, right? So I'm really, we need to do the perspective data because it's the chicken or the egg, right? So you really don't know what might be driving what, and it's way less convincing to be presenting these cross-sectional patterns. So I think eventually, yes, with these, larger data sets, longitudinal samples, sex-balanced samples, which are almost impossible to find in the current literature. That's why I do a lot of these studies, to actually recruit the age-matched men and women and hopefully follow them over time, in order to get to the point where we want to change criteria. But I mean, this is the literature, this is out there, and it's consistently replicated where we need to consider like a sex-specific lens, right? When we're talking about insomnia. They're kind of already doing that a little bit with OSA, but I would say less so with insomnia. In terms of insomnia and Alzheimer's dementia, we're not even close to there yet in terms of looking at these sex-specific potential considerations. But I think that's where we're going, and that's definitely where my mind goes when I think of the clinical impact here.
Great, thank you. Any other questions? I think everything was addressed in the chat. Any other questions for Dr. Curtis? Great. Well, thank you again for a wonderful Grand Rounds.
You're so welcome. Thank you.
Take care.